Welcome back, future colleagues, to Master Oral Path. Today, we're jumping straight into a high-yield diagnostic deep dive on reactive lesions and traumatic ulcerations. Look, if you're going to be treating patients, you are going to see ulcers. They're absolutely the most common oral soft tissue lesions you're going to encounter in practice. But honestly, knowing exactly what caused them and, more importantly, knowing exactly when to worry, well, that's what separates a good clinician from a truly great one. So let's get right into it. I really want you to approach today's review like a clinical diagnostic mystery. We aren't just going to sit here and memorize textbook facts. We're going to move step by step, from the initial scene of the injury all the way to your ultimate treatment plan. Because when a patient sits in your chair complaining of a random sore spot, you need a mental algorithm, locked, loaded, and ready to go. Here's our roadmap for today, which mirrors the exact SOAP note structure you're already using in the dental clinic: etiology and pathogenesis, clinical features, histopathology and immunopathology, differential diagnosis, and finally, treatment and prognosis. Okay, Section 1, etiology and pathogenesis, the scene of the injury. We start our workup by identifying the root cause, because as we know, an ulcer is basically just a physical loss of epithelium. To treat it, we've got to know how that tissue was lost in the very first place. So there are four main culprits for mucosal breakdown. By far, most ulcers are just simple mechanical trauma. A patient accidentally bites their cheek, or maybe their new dentures rub a little too hard. But look closely at those other categories. Chemical burns are a surprisingly huge one. Patients will literally place a whole aspirin tablet directly on their mucosa thinking it'll cure toothache, and boom, severe coagulative necrosis. Thermal burns are classic too. Hot, sticky foods like pizza cheese roasting the hard palate or hot liquids burning the tongue. And what's absolutely crucial for us to recognize is iatrogenic trauma. Yeah, injuries from the negative pressure of your saliva ejector, chemical burns from 30% hydrogen peroxide, or mucosal damage from acidic etchants. Those are entirely preventable by you, the clinician. Respecting the fragility of oral soft tissue is a big deal. Oh, and don't forget radiation and chemo. That mucosal ulceration typically kicks in about 10 days after they start therapy. Now, what's really interesting is this very specific presentation you just have to know. Definitely highlight Riga fetus disease in your notes. This is a traumatic ulcer located right on the interior portion of the tongue in infants. It's caused by the constant rubbing of natal or deciduous teeth against that delicate little tongue tissue. It is super highly testable, an absolute classic board exam buzzword, and just a perfect example of a highly specific mechanical etiology. Then, on the complete opposite end of the spectrum, we have factitial injuries. These are self-induced lesions caused by an abnormal habit. I'm telling you, these self-inflicted injuries are incredibly frustrating to diagnose in clinic because they just don't make sense. They follow a totally unpredictable course. The patient might not even realize they're doing it, or, they might be actively hiding it from you. Ultimately, these cases take a lot of sensitivity because actually fixing the physical ulcer might mean addressing an underlying psychological problem through counseling. Section 2, clinical features, examining the evidence. Now that we know the causes, how does the patient actually present in your chair? What exactly are you looking for when you pull back that cheek? To build that mental diagnostic algorithm we talked about, we absolutely must contrast an acute presentation against a chronic one. Honestly, your entire clinical decision-making process hinges on distinguishing between these two specific states. The contrast here is just stark. An acute ulcer is going to scream with pain. It's got this yellow fibrinous exudate at its base and is surrounded by a really angry red inflammatory halo. If you remove whatever caused it, it heals right up in about 7 to 10 days. But look at a chronic ulcer. This is where things get dangerous for us. Chronic ulcers are deceptively painless. They still have that yellow base, but instead of that red halo, they have these elevated indurated margins from deep scar formation and chronic inflammation. That firm raised border, it can easily fool you into suspecting squamous cell carcinoma. Section 3, histopathology and immunopathology, under the microscope. To truly master oral pathology, we can't just stop at the clinical surface. We need to understand why on earth these chronic lesions just refuse to heal. Down at the microscopic level, chronic ulcers are basically at a complete cellular standstill. You're going to see a base of granulation tissue with deep scar formation underneath, all packed with a mixed inflammatory cell infiltrate. But why doesn't the epithelium just grow back over it? Well, pathology tells us this regeneration failure might be due to inappropriate adhesion molecule expression, specifically integrans. There's literally an inadequate number of extracellular matrix receptors for the keratinocytes, so the cells literally cannot grab on and crawl across the wound to close it. The whole healing machinery is just broken. Let's look at a very specific, aggressive form of chronic ulcer, the traumatic granuloma. This happens when tissue injury and inflammation extend incredibly deep, straight down into the subjacent skeletal muscle. You'll see this a lot on the tongue, where trauma is super common. Histologically, it's got this dense infiltrate of macrophages and eosinophils nestled deep in the muscle fibers. But hey, a quick word of warning for your exams. Do not let the name fool you. Yes, it's called a granuloma because of all those macrophages, but it is entirely reactive. It is absolutely not an infectious granuloma like you'd see in, say, tuberculosis. Now, what's really fascinating here is the immunopathology side of these deep traumatic lesions. Recent studies show that when you look at these, you might actually find large numbers of CD30-positive atypical lymphocytes, which is wild. It's led pathologists to suggest that this condition isn't just some simple scrape. It might actually be part of a complex spectrum of lymphoproliferative disorders. It's just a prime example of how a basic clinical traumatic ulcer can be incredibly complex when you get down to the molecular level. Section 4. Differential diagnosis, lining up the suspects. We've arrived at the absolute most critical pivot point in our clinical workup. This is where we have to identify the dangerous lookalikes. So here's the million-dollar question. What happens if you've eliminated the suspected traumatic cause, like maybe you smoothed out a sharp tooth or adjusted a denture flange, but the lesion just remains? At this exact point, you have to immediately expand your diagnostic suspects. You can no longer just assume it's a simple reactive lesion. When a chronic ulcer doesn't heal, these 4 heavy hitters need to jump right to the front of your mind. We're talking primary syphilis chancres, infectious granulomas from tuberculosis, deep fungal infections, and, of course, the absolute worst-case scenario, squamous cell carcinoma. Because chronic traumatic ulcers develop those firm, raised, indurated margins, they can perfectly mimic SCC clinically. An accurate differential diagnosis here is literally the only thing standing between your patient and a missed malignancy. We just cannot afford to be complacent. And that brings us to our final step, Section 5. Treatment and prognosis, the action plan. Let's execute our clinical management based on all this evidence we've gathered. Your initial treatment needs to follow a really strict, logical algorithm. Step 1 is obvious but weirdly overlooked. Observe the area and completely eliminate that traumatic cause. Step 2, have the patient use a bland mucolytic rinse, something simple like sodium bicarbonate in warm water, just to keep the ulcer clean and free of debris. Step 3, if they're in considerable pain or if you're dealing with one of those stubborn traumatic granulomas, apply topical or intralesional corticosteroids. It provides palliative relief and actually helps accelerate the healing process. But listen to me closely on this next part, because everything in our treatment plan, everything in your entire clinical protocol revolves entirely around this single, uncompromising number, the number 2. The 2-week rule. Burn this into your brain. If an ulcer does not heal within 2 weeks after you have removed the suspected irritant, a biopsy must be performed. Board examiners are going to test you on this, and honestly, your future malpractice attorneys will expect you to know it too. 2 weeks is the grace period. After that, a biopsy is absolutely mandatory to establish a definitive diagnosis and completely rule out neoplasia or deep infection. There are 0 exceptions to this rule. So, as you head back into the clinic this week, ask yourself this question every time you pick up your mirror. Are you actively preventing iatrogenic trauma with careful technique, or are you just waiting to catch a malignancy disguised as a chronic ulcer? Remember, vigilant diagnosis and knowing exactly when to pull the trigger on a biopsy is your ultimate responsibility to your patients. Keep mastering your pathology, keep looking closely at those soft tissues, and I'll see you in the next session, right here on Master Oral Path.